Thanks, Cole. I prefer just family doctor. I think that kind of summarizes most of that quite nicely. And the other bit gets a little bit scary. So yes, thank you very much for the introduction. Thanks for asking me to speak today. I had quite the task put to me is to summarize the epidemiology and statistics of opioid use disorder in the city right now, summarize current best practices in treatment, talk about the connections care model, and where we might be going in the future in 15 minutes, piece of cake. So I may talk fast, but I think we're actually ahead of schedule, and we've got discussion afterwards. So I'm fine if people want to put their hands up and ask questions or interrupt me and kind of go from there. So I'll try to whip through that. I think most of this you guys will know. I think it's just to kind of ground us in sort of our current state knowledge right now and to kind of get us all on the same page as to kind of what we're all dealing with every day and make sure that we're all talking about the same things. I'm going to just sidetrack my presentation a little bit. So as well as a family doctor, I think something that got me thinking when Francis was speaking earlier about how much this affects so many people in BC right now. And my uncle was a person who injected drugs and was actually a patient of DCHC way back in the day and ended up on methadone for many years and did great and ended up passing on from something else. His partner had HIV. And some of my earliest memories actually is we're going with my dad, he had a van, and moving my uncle from SROs to SROs in the downtown east side. And I think that for whatever reason, my life has kind of led me to the downtown east side. Gabor Mate was my family doctor, and he delivered me. And then Dr. Joe took over Dr. Mate's family practice in East Van. And Dr. Joe was my family doctor for a little while. And I remember, yeah. And then I started doing residency in Victoria and started doing electives at Kool-Aid there. And it quickly became clear to me that the sort of inner city work was sort of where I was meant to be. And so I haven't really left since then. So it's been quite the experience. And again, speaks to how much this has affected certain families throughout the province. So I don't have any disclosures other than that personal one. So the objectives, like I mentioned, sort of review a little bit of current state, current best treatment guidelines and recommendations, and then to talk a little bit about the connections care model, which is the new program that Jeff West and a few of us here have been working on the last few years. So we know this. We're using the DSM-5 for defining opioid use disorder. It's a pretty kind of standard definition. It's the same that's applied for stimulant use disorder or alcohol use disorder. It's all the same terminology, taking more than intended, wanting to control use, and you get mild, moderate, or severe depending on the number of these features that you have. I think most of the patients that we see anyway, for sure, technically meet the severe categorization for having a lot of these. By the time they're sort of end up in the downtown east side, most of the folks are in the severe category. Just on a more simple level, I generally think about it as the 4 C's, cravings, compulsive use despite consequences, and loss of control. I can't remember all the 12 criteria, and I don't break them out when I'm talking to a patient, but I think about those 4 C's. That's a shortcut for any sort of addictive process, or most addictive processes anyway, are those 4 C's. And then prevalence, we don't have good Canadian data, but in the States, depending on where you read, you'll see about 1% to 2% of Americans with an opioid use disorder, and so probably somewhere in that same ballpark for Canada is generally what you'll see. And we've all seen this slide, unfortunately, probably too many times the last little while, showing this is not just opioid use, but all illicit drug overdose deaths since 1991. When I, just without telling you how old I am, when I finished med school, it was 200 deaths per year. When I finished residency, it was 300. And last year in 2016, it was 976. And I haven't been to finish residency for that long. So things aren't getting better, they're getting worse, if that graph doesn't tell you that. And we're on pace for, again, probably about 1,500 in 2017. This is another one that I think is important, where it shows what the coroner's office calls external deaths. I like to think of them as preventable deaths. I think that's a better word for it, because these are preventable. He was comparing drug overdoses to motor vehicle-related accidents, accidental drownings, fire-related, winter sport-related activity, which apparently gets its own category, and again, drug overdose dwarfing all of those. And again, I think that helps you put the context of, think of all the infrastructure we have to make driving safe. All the things that happened to you today on your way to getting here today that made that journey safe for you. You know, seat belts and traffic lights and whole divisions of the government that are just responsible for keeping that one part of your life safe, and how little substance users have in that same sort of respect. These are preventable deaths. And then again, I think you probably will know this just based on your clinical experience, but a little bit of data regarding who's being affected by the overdose deaths. Basically, there's about a 4-to-1 ratio of male to females in the deaths, and that's been pretty consistent throughout the years. Even though the numbers have gotten higher, that ratio has been the same. And the most dangerous age group is that 30 to 39. And I think that probably fits with what most of us see. Mostly males, mostly in that kind of middle age. I'm going to say middle age. Although the range, interestingly, of overdose deaths from 2000, I can't remember exactly what the range was. The youngest was 14 and the oldest was 76. So this affects everyone. This is another important one. This looked at the number of overdose deaths by place of death, place of injury, they call it. And almost 90% occur inside, and 60% inside private residences. And I think this shows, one, to me, how much overdose prevention sites and Insight and all the amazing community work and peers and Bandu and all that stuff that everyone's doing to kind of be out there in the community and having your naloxone clipped to your backpack. I think it shows that we're catching those people. If we can see you, if we can keep an eye on you, if we can have a peer nearby, that works. But what we're missing are the folks who are using alone in their rooms, who aren't connected to care, who don't have peers, who don't have friends to support them. Those are the folks that we're missing right now when it comes to deaths. And I think we have to, anything that we can do to capture that group is going to be super impactful. Okay, so that was my stats. And take a breath. I have to take a breath. So treatment. So Rolando introduced this. So this is the DCHC opioid use disorder guideline, which just was published in June 2017, and I was lucky enough to be part of the committee that worked on that, and as well as the previous Providence VCH guideline in 2015, which really took sort of province-wide group of clinicians and researchers, and there was nurses, and we had some peer voices review it and external reviewers to kind of review the literature and help come up with some evidence-based recommendations from a sort of BC perspective. Simultaneous with this guideline being released, the BC Centre on Substance Use also took over the administration of the methadone and Suboxone training for prescribers and sort of dispensing of licenses and that sort of thing. So that's been sort of some changes happening recently. I've got a BCCSU preceptor coming this afternoon to Connections, so it's a work that's happening. Rolando preempted me again, stole my slide. But this, and I think the reason we use this one a lot is because it's such a great slide. It covers so much of what's in that guideline. And with that foundation of harm reduction, and couldn't agree more with Rolando about it not being an either or. I often get in arguments with folks and say, all of medicine is harm reduction. It's silly to, when I'm treating diabetes, I'm reducing the harm of diabetes. When I'm treating CHF, I'm reducing the harm of CHF. We have these weird ideas when we apply it to substance use, and I don't know why that is, but it's what we do every day in most other things that we treat, and for some reason it's controversial for folks who have a substance use disorder, and I don't know why that is, but here we are. So foundation of harm reduction across the spectrum, and then various treatment modalities from low to high intensity. I should point, and I wish that this was more highlighted in the slide, and again, Rolando alluded to it with the withdrawal management. It looks like on there it's sort of equal with the rest of them, but in the guideline it's actually explicitly recommended against. We do not recommend withdrawal only. There's clear evidence that there's almost universal relapse, higher rates of HIV infection and overdose death following detox. We do not recommend withdrawal management only. It doesn't mean people can't choose that option, but it must be accompanied by other treatment afterwards. It's not 1 week, you're through your physical withdrawal, see you later, good luck, you're on your way. It has to be accompanied by something else. It doesn't have to be oral opioid agonist therapy, but it has to be something else, whether that's intensive outpatient support or residential treatment or something. But withdrawal management on its own is not a good option. And the bread and butter is the agonist therapy, whether it's the stuff in the middle, which is our methadone and Suboxone, or the more specialist-led programs, your sustained release or morphine or your injectable options. And we know that there's lots and lots of positive outcomes associated with methadone and Suboxone. Treatment retention, withdrawal suppression, decreased illicit opioid and cocaine use, decreased risk of Hep C and HIV, increased ARV rates, I mean, you guys can read, decreased criminal activity, and significantly reduced mortality, both all-cause and drug-related. Just to delve into that a little bit further, this was a good study from 2016. It was a national cohort study in Ireland where they looked at 7,000 patients for 6 years on their methadone program. One of the things I like about it, it's methadone delivered through primary care, which is mostly how it's done in BC. And then they looked at drug-related mortality. And on treatment for methadone, it was 0.24, and off treatment was 0.39, so about half the drug-related mortality rate, which is pretty huge when you think about a lot of interventions that we do in medicine. But I think even more interesting about this study was that they also looked at all-cause mortality. And that's where often other interventions we do in healthcare kind of fall off the map a little bit. Things we do for screening for colon cancer or interventions for heart disease may affect heart disease positively or colon cancer positively, but then when you factor in all-cause, the numbers drop. But it's actually the opposite with methadone. The all-cause mortality on treatment, so if there's any reason, was 0.51 versus 1.57. So almost 1/3 the all-cause mortality rate for someone being on methadone, which is huge. That's a huge difference in someone's, like, death from any reason goes down by 1/3 from being on methadone in this study. And again, delivered through primary care, not through necessarily specialists or special programs. This is just family docs and family nurse practitioners and primary care nurses. And the mortality rate, when they were looking at on and off treatment, was highest in the initial 4 weeks off treatment. So that again, that fallen folks who we lose, folks who can't sustain treatment, it's that initial 4 weeks which is the most dangerous. So again, showing that. This is a tiny slide, you don't need to do this, I just wanted to show it. This is from the BCCSU guidelines, so I think it's all in your packages. Just talking about the differences between methadone and Suboxone. The guideline kind of focuses a bit more on Suboxone as first line and methadone second. I prefer 1A and 1B. I think they're both, I think of them as pretty equal co-first line agents. And from Connection's experience, we're probably at about 80 to 85% methadone and about 10%, 10 to 15% Suboxone. So we're still seeing, at least in our population in the downtown east side, methadone is definitely the preferred option. And I think there's probably 2 main reasons for that. One is just the difficulty of handling withdrawal, not being able to, for someone who's injecting 5-6 times a day, trying to get 12 hours without use is pretty challenging. But I think the other thing, and I think Barb, Eddie, and I were talking about this yesterday, is that so many of our folks, abstinence isn't the goal. And being okay with that as providers is something that I've had to learn to get to, and to not, when I'm asking folks about their goals, and give people permission for that not to be their goal. I think people often tell us what we want to hear. And for Suboxone, there's the perception out there that that's for abstinence, and there's some truth to that, and that it gets tricky, the timing of taking your Suboxone if you're still wanting to use, whereas for methadone, we have so many folks who just want to contain their use, control their use, go from using 1 gram a day and doing sex trade work to going to using a point a day and on their own terms, and not being in that desperate situation. And so giving our patients permission to tell us that and to be honest with that, and for us to be okay with that and be like, oh, that's cool. The question that I always ask my patients is, tell me how your life is going to be better with what we're trying to do right now. You can tell me how your life is better, cool, I'm on board. I don't really care about anything else. If your life is going to be better, then that's good for me. I was also asked to talk a little bit about psychosocial interventions for opioid use disorder. And so this is a little bit outside my wheelhouse, and Chris and from Pender and some other folks will probably jump in if I'm, but I did look into some of the data a little bit and looked at what the BCCSU says. And there's some interesting stuff. So this was a big study, again, from the UK. Let me just see. Yeah, from England, 2016, where they, again, a national cohort study comparing opioid replacement and residential treatment and psychological or psychosocial support. And the interesting thing here was actually that psychosocial support on its own actually increased mortality rates compared to no treatment. So that's interesting. Opiate replacement sort of was about half, which is similar to the data we saw in the other study. Residential treatment was a little better than no treatment, but again, opiate replacement was still far and away best. Psychological support on its own actually had higher mortality rates. So that's interesting, but let me just keep going a little bit. Where there's better data is psychosocial support combined with opiate replacement therapy, and that's where this seems to be the sweet spot. And so there was a good systematic review from 2016, I believe, where again, they looked at exactly that, all the different studies where they combined various psychosocial interventions, different counseling techniques. They kind of lumped them all together, so I can't say one in particular one is better, and again, Chris maybe could tell me if there is more evidence for particular interventions. But for all the folks, all the studies where they looked at methadone combined with psychosocial, 9 out of the 14 studies showed significant positive effects on outcomes. Treatment attendance and retention, decreased use, decreased HIV risk. Again, kind of fits with what we would guess from our clinical experience, that when you combine it, you're kind of getting the best out of both. Same for Suboxone, it was slightly less robust, the evidence. There was 3 out of 8 studies that found significant effects for the combination, but with similar effects on treatment retention, completion, and attendance. So that seems to be where the big bang for your buck is combining the things, the 2 different interventions. And then I just wanted to touch a little bit on some of the emerging options. So we've talked a little bit about sustained release oral morphine. This is done in certain parts of Europe a bit more commonly than it's being done here. And as part of the VCH guideline and now the BCCSU guideline, we got it added as a third-line treatment option. So the formulation we use here is Cadian. There's various versions in Europe, but it's a once daily, 24-hour morphine. Same idea as methadone. You go to the pharmacy every day, you get a witness dose, and the evidence definitely shows one of the issues with methadone is its effects on cardiac rhythms, and you can get this prolongation of the QT interval. It doesn't really matter. It's a potential side effect of methadone that you don't get as much with morphine. So that's nice for some folks who have that complication. But there also is some good evidence, it needs to be replicated a bit more, but that it actually, folks get less cravings than with methadone, fewer side effects in totality, better, and it seems to have some better effects on dysthymia and mood symptoms, as well as there's a good study comparing folks, and we've particularly seen this with the move from methadone to methadose, who just say that the methadone doesn't hold them 24 hours. I'm sure we've been hearing that. And so there was a good study where they looked at non-methadone holders, so the folks who really said it's only lasting me 16 hours, and switched them to Cadian, and they did a lot better. So again, a little bit early days, and we're all kind of gaining clinical experience here, but there's good signals for it being a third-line option. And we're probably at about 5% of our patients right now at Connections on Cadian, and so far it's been going well, no sort of issues. And then also, I know we're focusing on oral treatment, but injectable options is definitely something that I think we'll need to wrap our heads around in the next few years, and that I think we should all be kind of letting, not necessarily, don't have to wait a few years. Yes, thanks, Dave. But the expansion, it's going to take some time. But I think at the very least, it should all be percolating in our brains as to where does this fit, and how can we think about when we're planning future spaces for all of our programs, and it just should be in there somewhere. And again, like Rolando mentioned, we know that retention rates for Suboxone and methadone, and this is sort of across the literature, aren't amazing. 40 to 70% discontinue both treatments in the first year or so. And for those folks, prescribed acetylmorphine or heroin seems to be quite beneficial. And again, the summary from the BCCSU was that 70 to 90% retention with diacetylmorphine, and 80% for when we were using hydromorphone. And then I stole this. There was a recent symposium in Vancouver on prescribed heroin, and this is from the German group that was there, and they presented their research on comparing heroin-assisted treatment versus methadone. And they found higher retention, higher reduction in criminality, better quality of life, better working ability, less alcohol, anyways, all good things. So the evidence is pretty clear. That was one thing that I took away from that symposium in the spring, was that the evidence is pretty robust for prescribed heroin being effective. And so I think it's something that we all need to be pushing for as well. Okay. Good. Barriers. So we know methadone and Suboxone work. We know that Acadian has a role and then injectable treatment has a role. So what are the gaps and what are the problems? And there's lots, and I think we know this. Just the access, just the basic access, the number of methadone prescribers, particularly outside of Vancouver, but even in Vancouver isn't enough to meet demand. Intake processes everywhere, all of our programs all have separate processes for getting on methadone or Suboxone, and that can be hugely challenging for folks. Titration is an issue, just the clinical environment where somebody needs to get care. MSP and pharmacare coverage, although that's improved recently with the Plan G changes, adding methadone and Suboxone to Plan G has made a huge difference. Clinic fees. So again, we were using HIV as kind of a touch point here, but can you imagine if in order to get your HIV care, you had to pay a clinic $60 or $70 a month in order, like, it'd be crazy, no one would stand for that. But that's still the case now for most methadone clinics, is that you need to pay, you need to have a fee just to get in the door. Pharmacy fees, that's dispensing fees. Again, these medications are usually as daily witnessed or daily dispensing, so if you're not on income assistance, you know, that $10, $15 a day you're spending on just dispensing fees. The supervised dosing and just how that affects folks' lives, their ability to work and go to school and connect with their families, that's a barrier. Missed doses, so again, folks who that titration process gets interrupted or they need to restart because of missed doses. And then just ongoing maintenance and being able to maintain that. So with those barriers in mind, and as part of the Downtown East Side second generation strategy, which I'm sure we're all aware of, been going on forever, one of the things that was identified in that process was the need for a low threshold methadone or addiction clinic in the Downtown East Side. And so that's when I and myself and Jeff and Ron and a few others in the room became involved with this program, this working group where we were looking at, okay, how can we do this? This was identified by the community and by our care providers as a gap. And then we lucked out in having Irene and the CFE have this new space that they were offering to let us have some of it or to use some of it. And so we started planning for a low threshold clinic in the Downtown East Side. So the plan was to provide a care team and facility in the Downtown East Side for folks with untreated opioid use disorder who have proven difficult to engage and retain in care. And the objectives were to engage this population, address obstacles, and generate pathways to care. So after a lot of years of meetings and working groups and IT infrastructure to work through, now have the Downtown East Side Connections Clinic, which is between Princess and Heatley on Powell Street. We actually started, because we were getting so frustrated with just the usual things, construction delays and getting IT to the site, we actually started in the fall of 2016. Jeff, JC, and I, and Dr. Satter from Native Health, we just said, we're just going to start doing it. We don't have the space. We're just going to start doing it at DCHC. We kicked Monda, our clinical coordinator, out of her office. She came into work one day and all her stuff was gone. And we had just started a rapid access opioid clinic just out of DCHC. And it was, so we were doing 3 to 5 half days a week. JC was running around like crazy, seeing everyone that she could, and I was sitting in the back signing prescriptions. And it was awesome. And like we saw, you know, we were starting 4 or 5 people a day in just half days, and then while we were getting everything ready to move into our beautiful new space in March of this year. So our plan, and I just took these slides off of a presentation I think I did for, I don't know, someone before we had opened, because I thought it'd be interesting to pull them back and to reflect as I was talking if we had actually been able to achieve these things. So this is what we wanted to do. So we wanted to have an accessible 7-day-a-week program that was open 365 days a year, including physician coverage 365 days a year, in the Downtown East Side, close to other services, with a low barrier, philosophical approach, no fees, and able to serve clients who didn't have MSP coverage. So I think for the most part we've hit all of those. I don't think we've had any day, I think we've had physician coverage at least 90% of the day, every day that we've been open so far. Holidays, Ron Joe has been our sort of savior whenever we've had a desperate weekend day that we haven't been able to get filled. And Ron came in one day and the nurses told me the next day that he was sick, and she walked into the room and he was curled up on the treatment bed with his jacket on his shoulders. still writing prescriptions and seeing patients. So, so thank you, Ron. We wanted to have an engaging space, so we have 2 meals a day. We have a hot breakfast and lunch every day that the PHS provides for us. It's not a waiting room. There's no waiting room chairs. We've got couches. We've got my Netflix account, so you can watch Paw Patrol or or whatever you like on Netflix on the big screen TV. We've got a ping pong table and coloring books and 2 computers in the back with internet access and a phone for folks to use. We have a full-time social worker. We have peers and community liaison workers. One thing that we had hoped for was this on-site supportive groups, and that's something that we haven't had a lot of group programming yet, and that's something that we really want to do and we really wanted to do. But we've been actually just our volumes have increased so quickly in our room as the sort of drop-in loungy part of it has become so popular that there isn't a lot of space for doing that, and we've just been so busy kind of doing the bread and butter. Luckily, we have access to the DCHC programming half a block away, and the new Powell Street Getaway, also another sort of half a block away, so we're kind of taking advantage of stealing some of their services to cover that gap. But it is something that we were hoping for that we haven't been able to achieve yet. Obviously, it's the harm reduction approach, where reduction in use is the primary goal, but not abstinence. We distribute take-home naloxone and harm reduction supplies. And our goal was to have efficient and expedited intake. So our goal that we set for ourselves is what we call the door-to-dose time of 120 minutes. So someone, brand new patient, walk in the door, say hello to the front desk, and have a methadone or Suboxone, not just a prescription, but the actual medication in their hand in less than 2 hours. And I think, again, Jeff can disagree, I think we're hitting that about 95% of the time, and likely, most of the time it's probably less than that. So I think we're doing pretty well there, and that's mostly because of our awesome nursing team that whenever I'm orienting a new doc, I say, just do what the nurses tell you. They're doing all the heavy lifting. So they do everything. They do the intake assessments, they do vital signs, they do the intake blood work, they do a UDS, they do an addiction history, they check Pharmanet, they package it all up. Usually they come to me and I say, methadone 30 or Suboxone 4, and they tell me what to do. So that part's been awesome. And like I said, on-site phlebotomy and CareConnect access and all those regular things. So the other big thing that we have at Connections is an in-house health authority pharmacy, and that really enables us to sort of reach that crowd that doesn't have pharmacare coverage or MSP, and that's been a huge win. And it also means that we have folks coming through our doors every day. So we have about 200 active clients right now, and we see most of them every day coming through the door, getting a snack, getting their dose, and that's been awesome. And the pharmacists are part of our morning huddle, and so they're just part of the team. We have the outreach capacity, so our CLWs outreach, so just like Rolando was mentioning what they did at the CFE, our clinical coordinators, all the blue copies of our scripts go to the clinical coordinator, and we have a spreadsheet of every prescription that we write, the dose, when it starts, when it ends, and that gets printed out for the CLWs every morning with highlights as to whose dose expired the day before or that day, and they try to outreach as many as they can and pull people in. And then often what I'll do on Fridays is before I leave on Fridays, I'll get the list, and particularly if we're a little light on coverage, I just extend everyone till Monday, so just to make sure that we don't have folks getting stuck on the weekend without prescriptions. The other big thing that we do it's been awesome is we do bridging support for the community. So what that means to us anyway is that someone who's missed their doctor at a private methadone clinic or Pender or Sheway or wherever can come in on a Saturday and they're on 140 methadone, and we'll cover them. We'll provide them with scripts and just cover the 2 or 3 days until they can see their regular prescriber, and that's been awesome. I love that part because I've never got so many hugs in my life from folks. I'm like, oh, sure, you're on 150 for 6 months? Okay. And I do a 2-day script and people are blown away and think I've done something so amazing, and it's been a really nice sort of feature that we've been able to do, so that's been great. And then I think a couple of other big things that we have family doctors who work there who do addiction, not addiction doctors, and that was something that was really important to us, is that we'll manage your cellulitis or your hypertension and talk about your hep C or your diabetes as well. We try to do as much as possible while you're with us. We'll do all of your care. We don't want to have to send you off somewhere else. And we're also really lucky in that we've got our current team, I actually was writing it out, we've got docs from Native Health, Spectrum, the Portland Society, DCHC, PAUSE, START, Alliance Clinic in Surrey, Royal Columbian Inpatient Addictions, who else? Ravensong, but anyways, all over. So we've got docs who work all sorts of different other places in the community. Same with the nurses. We've got nurses from Insight, from Emerge, from PAUSE, from Primary Care, from the ACT team. So it really helps us transition folks, do warm handovers, talk to their other programs about what we're doing and how we can work together. And that's been sort of one of the things that's been really successful. And then being sort of right below the CFE and the Center on Substance Use, we're hoping to have lots of sort of research opportunities. And there's already a couple clinical trial grant applications in process where Connections would potentially be a site if all goes according to plan. We do have some safety things in order to try and make this, as well as providing quick, rapid care, but also really safe care. We think the on-site pharmacy really makes a big difference. It's, you know, skilled pharmacists who are not, I don't say this positively, reliable pharmacists, I'm just going to leave it at that, good reliable pharmacists who are doing proper witness ingestion of doses and communicating with us any concerns they have. We don't do carries. We're a transitional program for methadone anyway. So when someone's sort of ready for carries, we say, great, you can graduate from Connections and we'll help you to move on to somewhere else. We don't do any benzodiazepine prescribing except on controlled tapers. So we have pretty tight parameters and a sort of a policy document that all new physicians sort of I review with when they start so that we're all practicing in very similar ways. So we get very little kind of splitting. We all kind of practice, we've all agreed to sort of certain parameters and that they're very transparent right from the start, and patients, clients know that right off the bat, and helps to make things quite smooth. That being said, of course, we've had challenges as well, and that transition piece has been probably the biggest one, is that, again, because there isn't enough capacity in the province and the community in general, like I said, we're at over 200 folks right now, which we figured was going to be about our capacity, but we're not turning people away. We've done, I think it was 50 starts in the last 30 days from the last data I saw, so we're still, and that was actually a quieter month than the previous one. So transitions is definitely a challenge, and trying to find the right place for folks depending on their situation. Staffing, again, particularly for the physician prescriber side, we're kind of stealing from other programs. It's the same kind of group of us in the downtown east side who tend to work at multiple different programs, because you can see by all the things I have touched my name. So we're kind of spreading a lot of us pretty thin and stealing good nurses from ACT and PAUSE and Insight and, you know, that kind of thing. So that's an issue, is that we just need more skilled staff at all the sort of different levels. So there's been some challenges for sure. And then bridging. There's been a few funny things where now that the kind of word is out that we do this, and this was the same sort of thing that was happening with the mobile medical unit. Like, oh, I don't need to bother going to see my doc on Friday afternoon. I can go to Connections on Saturday. And I mean, not the end of the world, but it just affects our capacity a little bit. And you know, you do want people who have a team involved for them to be sort of still the main team. There was one clinic that also decided to close early one Friday and just put a sign up, said, oh, just go to Connections. So that wasn't ideal without asking us. But, but overall, things have been going really well. I don't know, Jeff, did I miss anything brilliant for Connections? Whew. Deep breath again. A bunch of references if anyone's really curious. I'm open to, I think we've got time if there's like specific questions about Connections or, oh, I know, I checked the other day, this is something I want to say, since June, I've done 800 methadone prescriptions at Connections, so it's busy.